ASCVD morbidity and mortality in both primary and secondary prevention settings. In the randomized trial with 5 years follow-up, the relative risk reduction with statins has been in the range of 25 to 45%, and it is estimated that long-term treatment would produce even greater risk reduction. Pleiotropic beneficial effects. The inhibition of the enzyme, coenzyme HMG reductase also leads to inhibition of the synthesis of isoprenoid intermediates. Isoprenylation of proteins is involved in the activation of inflammatory pathways and in vascular remodeling in disease states such as atherosclerosis and diabetes. Blocking these metabolic pathways by statin protects against the progression of atherosclerosis. In addition, statin also acts at several other steps involved in the process of atherosclerosis. They reduce platelet aggregation and activation in both cholesterol dependent and cholesterol independent manner, reduce the pro-atherogenic effects of oxidized LDL, improve endothelial function by promoting endothelial progenitor cells proliferation, migration and survival, reduce vascular smooth muscle cell migration and proliferation. Two key steps of atherogenesis: stabilize the atherosclerotic plaque through lipid lowering and by decreasing the expression of matrix metalloproteinases and tissue factor, and also decrease myocardial remodeling following myocardial infarction by inhibiting some effects of angiotensin II such as cardiac fibroblast proliferation, collagen synthesis and induction of cardiomyocyte proliferation. A proposed mechanism for the anti-inflammatory effects of statin following an acute coronary event is through the reduction of phospholipase A2 biomarkers. Apart from these lipid-modifying actions, statins also have a numerous pleiotropic effects as described below. Collectively, all these actions result in profound ASCVD risk reduction with statin. Several large-scale randomized clinical trials have demonstrated that statins significantly reduce morbidity and mortality in both primary and secondary prevention trials. Clinicians need to make decisions regarding high or moderate intensity statin therapy depending upon the clinical situation they encounter. Discussion with the patient regarding statin therapy, highlighting the advantages and disadvantages with their use is an integral component of good clinical practice. So summarizing and recommendations are: the clinical benefit of statins depend primarily on the extent of LDL-C reduction and not on the type of statin used. The type of statin and the dose to be used should be based on the degree of LDL-C reduction that is required to reach the target LDL-C in a given patient. At least moderate to high intensity statin therapy is required to bring about a clinically meaningful reduction in LDL-C in most patients.